So I'll go ahead and start now. So this is a great study, I think, not just because it's mine, but because we're very proud of it. Thank you, appreciate it. We ran this from 2020, and we just finished recruiting about 6 months ago. This was an investigator-initiated trial, so not an industry-sponsored trial, although it was funded by industry through an external research program grant, so very grateful to Medtronic for funding this. This was a big investment and a big gamble, really, for them. What this study really aimed at looking at is whether the new version of what the actor formerly known as Super D, which is Illumicite, which is essentially a combination of electromagnetic navigation and digital tomosynthesis, which helps correct for city-body divergence. I'll talk about this in a little bit. Whether that resulted in sufficient incremental diagnostic yield benefit that now we can probably discuss about whether we're as good as our interventional radiology colleagues. So kind of an interesting study, certainly something that when I trained back in the old ages was inconceivable, that we would someday reach a level of diagnostic yield with bronchoscopy that approaches that of CT-guided biopsy. These are my disclosures. Anyway, we get funding for the study. I get some consulting royalties from Medtronic as well. This is a Medtronic-funded study, but again, investigator-initiated trial. And you can see my other disclosures here. I've got some NIH funding for biomarker and lung cancer, and a variety of other research funding. So the objectives of this short talk will be to review the data on CT-guided biopsy and modern navigational bronchoscopy. What do I mean by that? Well, some technology that allows us to navigate to nodules, but also to correct for that CT-body divergence that I just mentioned. And then I'll go over the study protocol, not in excruciating painful details, but just so you have a sense of what that was, and then the rationale for running the trial. This is the kind of nodules that back when I was a fellow in 2006, we didn't really think about going after with navigational bronchoscopy. It's pretty close to the edge. CT-guided biopsy is a straight shot. Why would you bother with navigational bronchoscopy? And these are the nodules that we go after now all the time because we know we've got a pretty good shot at it. So things have changed quite dramatically over the past 10 years in bronchoscopy in general, a plethora of new technologies. The diagnostic yield of transthoracic needle aspiration, if you read all the reviews on the topic, it's going to be about 90%. So this is from the ACCP guidelines for lung cancer meta-analysis. They did a really good job at looking at all the literature on transthoracic needle aspiration. If you look at the details, well, if the lesions are a bit smaller, the diagnostic yield may not be that good. There's also issues in the way we define the diagnostic yield. That's a whole other can of worms that we may or may not have time to talk about here today. If you look at lesions less than 1.5 centimeter, that sensitivity actually gets much lower than 90%, probably around 70 to 80%. There are downsides with CT-guided biopsy. It's a great technique, and when I was at Mayo, that's really the only technique we used back then. But there are downsides. One is the rate of pneumothorax, which is probably in the range of 7 to 8% for pneumothoraces that require chest tubes. Probably it's higher for pneumothoraces in general. But I think the main downside of CT-guided biopsy is that often we need to biopsy lymph nodes. Often we go after several lesions during the same procedure, and you can't do that with IR. So there are downsides that bronchoscopy may be able to help with. The problem with bronchoscopy is that at least in its conventional form, just the handheld bronchoscope and your screen and fluoroscopy, the yield is just not great. It's actually pretty horrendous. 34% for lesions less than 2 centimeters, again from the meta-analysis from the ACCP guidelines that I just mentioned. So better safety profile, the ability to go after several nodules, maybe stage the mediastinum at the same time, but in the absence of adjunct technology to guide us to the nodule and confirm that we're there, the yield is not good. Now, what we've seen over the past 10 years is this evolution of medical devices. That's really important because the way that we introduce medical devices on the market in this country is through the 510K FDA pathway, which really requires you to just resubmit an application if you have slight modification of a pre-existing device, and then it's reviewed, and if it's deemed to be substantially equivalent to the predicate device that's already commercialized, then you have a fast track into commercialization of the device. And what we've seen over the past 20 years is that sometimes it's a gradual, incremental change over time, such as better, video chips for bronchoscopes. Sometimes you get this kind of leap of evolutionary leap where you get a brand new device that's really disruptive. And we've seen this with EBUS, for example. I think the same kind of leap happened with the ability to visualize the nodule better. And this was with cone beam CT, and before that with digital tomosynthesis. Digital tomo is essentially a poor man's cone beam CT where you use your conventional C-arm, turn it around the patient, and get a nice, a good enough view of the nodule that would otherwise be invisible in fluoroscopy. You can then mark it, and then the system will recalibrate to steer you in the right direction. And so we went from the handheld bronchoscope to a brand new device here, and now we have on the market a plethora of devices, and the question is, well, which one should we use? And the response to this is that, well, we don't really know because they were all approved on the same principle of substantial equivalence to predicate devices, and we don't have great data. So that clearance pathway of the FDA has really shifted the responsibility to produce useful data that can inform patient care from the companies to us. And so now we have to do the studies when the product is already in the market, which is not easy because it's already approved. You're going to try to convince patients that they need to be part of a study, randomizing them to one or the other when both are approved, and you may have personal preferences and so on. So how are we doing? Well, we don't really know. This is a nice paper that came out in Chest last year. It's an updated meta-analysis from a paper that was published initially in 2012, looking at guided bronchoscopy. So all techniques of navigational bronchoscopy, including just a regular scope with radial EBUS versus electromagnetic navigation versus any form of navigational bronchoscopy you can think about. Not a whole lot of papers on robotic bronchoscopy, so not a whole lot you can infer from that. But the interesting thing is that they're really between 2012 and before 2012 and after 2012, you don't have a ton of change in terms of diagnostic yield. It's about the same, which is very interesting. Makes you wonder what happened, because clearly we feel anecdotally, experientially, that we're doing a whole lot better. So one of the reasons why I think that yield really hasn't made great strides is that only recently we've started really considering ways to deal with this CT-body divergence. So what is that? When you do a navigational bronchoscopy, whether you use robotic bronchoscopy or Illumicide or whatever, you're going to use the pre-op CT. So the patient's going to go to the CT machine, you ask them to take a largest possible breath they can take, and then they inspire, and then you use that CT at total lung capacity to kind of mark out the path to the lesion. The problem is that then you're going to get the patient intubated, ventilated, under usually general anesthesia. These lung volumes are very different, and they change because the patient's still breathing. You got to keep the patient breathing somewhat during the procedure, and so that nodule is actually going to shift quite dramatically. Then as you progress during the procedure, you get some atelectasis, little bleeding, whatnot, so it becomes more difficult. And so you need to be able to, during the procedure, readjust for that. That's where intraprocedural imaging comes into play. And up until 4 or 5 years ago, we didn't have any way to do that. So this is the example of what happened. So the navigational bronchoscopy procedure happens here. Your pre-op CT happens all the way up there. And so clearly you're going to have some issues there. This is what happens with digital tomosynthesis. So again, this is the poor man's cone beam CT that I mentioned that got integrated with the super dimension platform, now called Illumicide, which is the object of this particular study. But you can see here's the catheter, and that little nodule here is moving all over the place, right? And so you need to be able to adjust for that during the procedure, or maybe adjust a couple of times during the procedure. I'll just give you an example of how that works. We started using this in 2018, I think, is that right? 2018. We're kind of blown away by what it does. So here's a conventional 2D fluoroscopy where you really can't see the cavitary lesion at all. And here's what you see with this is a coronal CT cut. It's not that digital tomo, but I'll play the video here so you can see the corresponding image with digital tomo, if it works. Here it is. I'll play it again. right there. Not all that different. And that's fairly standard for what we see with digital tomo. Again, it's not a CT cut. It's, it's not nearly as good, but it's good enough. You mark it, and then the system's like, oh, okay, this is where we need to go. This is where you need to steer your catheter toward. So we started using this in 2018. We were like kind of blown away by how good it worked, and so we're like, let's do the research and look at before and after introduction of this thing to see if we've made any major improvement as we thought. So this was a before and after study. And I kind of like this study design actually for bronchoscopy because you control for everything else pretty much. Your population of patients should be about the same operators, same operating room, same rows pathologists, same everything. And the only thing that really changes your new intervention. So it's not a randomized study, but it's pretty good. And so we looked at the diagnostic yield, and the diagnostic yield went from 55, which is terrible, not good, not great, to 79%. That's an effect size that you never see in medicine. We're really excited about this. Now, when we talk about diagnostic yield, I should mention what that means here. We've always done our studies looking at a very conservative definition of diagnostic yield. In other words, if you get a biopsy that gives you cancer, that's diagnostic. If you get granulomas, it's diagnostic. If you get any specific histologic diagnosis that helps you take care of the patient, we consider this diagnostic. This inflammation, atypia, whatever, we consider this non-diagnostic. So these numbers are actually pretty darn good. And so we looked at it with a few other papers, and we're like, well, geez, we're about at that 80% diagnostic yield for our cohort of patients. We were at 50-50 before. That's a huge jump. So we're like, well, maybe we should think about actually randomizing patients and against the gold standard of CT-guided biopsy at that point. So you can refer to these papers here. We published probably 4 or 5, I think, on this technology. Now, a couple things about diagnostic yield. We defined the diagnostic yield in a consensus statement paper that came out in the Blue Journal just a few months ago. I don't know if you saw this. If you haven't, you should look at it. We've decided to define diagnostic yield as we defined it in the study that I just mentioned. And doing that, I think there's this misperception or misconception that now we are able to compare papers to papers, and this technology has 95% diagnostic yield, this one has 65% diagnostic yield. You need to take a look at the whole thing. You need to contextualize what that diagnostic yield means. Clearly, there's a difference between the sniper that hits a fly, a mile down the road versus this guy who's never going to miss the target. So it's important to understand that when we talk about diagnostic yield, there's hundreds of variables that will need to be taken into account that affects the diagnostic. The first one is how good of a bronchoscopist you are. If you're terrible, it doesn't really matter what technology you're going to be using unless it's a fully automated robot. But you get the pathologist in the room, you've got the pathologist in the lab, you have what kind of needle you're using, what kind of population of patient you're going after. If you're only going after 10 centimeter masses, you're going to be really good no matter what you do. But if you go after 1.5 centimeter lesions, then it's going to be difficult. So there's system issues, population issue, operator skills. And we're trying to infer from all of this stuff what the responsibility of the technology is when we look at diagnostic yield. The diagnostic yield is influenced by all these things. And what we infer from these studies is that the particular robot, the particular platform is actually responsible for the diagnostic yield. Well, you can't do that because you need to look at the whole thing. You need to balance both groups for all these confounding variables. You can do that with some adjustment, propensity score matching and whatnot, but you're always going to miss the ones that you don't know about. Where somebody who's like doing bronchoscopies in the afternoon. It's like the judges, giving more, better favorable verdicts after lunch. Maybe you're better in the afternoon or the morning. All these things you need to balance. The only way that we know to do this is with randomization. And so this is why it's so absolutely critical that given the incredible and unprecedented technological advances in bronchoscopy that we've had over the past 10 years, that we start doing good, methodologically solid randomized control trial. And this was really our incentive for doing this study. So going to bronchoscopy versus CT-guided biopsy is interesting. There's actually quite a few papers. I mean, not a whole lot, but there are some. Most of them are old, so prior to introduction of these new technologies that I'm talking about. You have a few RCTs that are severely underpowered, so probably not super helpful. You've got some good papers that have tried to adjust for confounding variables like size and things like that, bronchosine. But again, you don't have them all available, and you also have the unknown confounding variables that you can't account for. So this was the impetus to do VERITAS, which is an awesome acronym that unfortunately I didn't come up with, but I made it fit with the names of the titles. So this was a collaboration between the Interventional Pulmonology Outcomes Group. This is a group that we founded probably 4 years ago, and we just got a new website that I think is open. You can look at it now. And then VIPER, which is the Vanderbilt Interventional Pulmonary Research Lab. So we were able to convince Medtronic to give us the money for this study, which was a multi-center study. The objective was to compare digital tomosynthesis-enabled ENB to the gold standard of CT-guided biopsy. So non-inferiority study, we're not trying to show that we're better than CT-guided biopsy. That'd be crazy to try to do that. But what we're trying to show is that we're not inferior to CT-guided biopsy within a specific non-inferiority margin of 10%. We want to show that we are no worse than 10% less than CT-guided biopsy, which I think is a reasonable assumption to build this study. It was 7 US centers. The number that we needed to randomize for this study was 258. That was 224 patients, 112 patients per group, plus attrition, patients lost to follow-up and things like that. Inclusion criteria are pretty standard. The 10 to 30 millimeters because the instruction for use for Illumicite, which is the platform we're talking about, were for nodules 10 to 30 millimeters, or more than 10 millimeters, I should say. And then we wanted to only consider nodules that were located in the middle third of the lung or outer third of the lung, because it would be not really fair to CT-guided biopsy to ask them to biopsy things that, we can probably biopsy, but they really can't. And we had a pretty good design in that, we screened actually from interventional radiology services and interventional pulmonology services at all centers, so that we didn't cherry pick patients, and we don't have this kind of built-in, systematic bias, taking patients that would be preferentially going through IP. We asked them if they were interested in the study, and then we consented them. And then we had this really cool and great and really complicated central adjudication process where once the patient is consented, the CT scan is reviewed by an independent interventional radiologist, an independent interventional pulmonologist, and the lungs are segmented with an algorithm that we had used in prior studies. And that segmentation is really to make sure we stratify the randomization for middle and outer third. That's really important. We wanted the same amount of nodules in the outer third and the middle third in both groups. That central adjudication panel by IR and IP was to make sure that the nodule was indeed amenable to both interventions, because if it's not for IR, then we can't enroll the patient. It's not fair. And we had some objective criteria that they followed, but also if they said, we just can't do that, then they had to give the reasons why they wouldn't, and same for us, obviously. As I pointed out, the primary outcome was pretty conservative. This is diagnostic yield, but it's actually more conservative than the diagnostic yield we described in the Blue Journal, in that we also needed 1 year follow-up for all benign nodules to make sure that they were not, false negative. This is the enrollment. It took a while because we started here, that was September of 2020. We were on hold because the pandemic. And then when we reopened, it was kind of limited resources for research. We're dealing with more pressing issues at the time. But this was VUMC here, kind of slowly recruiting, and then we got a bunch of other centers. And then we had a fairly linear recruitment after that, but it took about 3 years to do this. This is why we're just now presenting the results. But it was 7 sites: Vanderbilt, Kootenai, which is a community hospital; St. Luke's, also a community hospital in Kansas City; Wisconsin, UCSD, Duke, and Rush. So a good mix of academic and community centers. These were the centers. This was a huge undertaking. This was my first, multi-center investigator-initiated trial. I've done industry stuff that's relatively a heck of a lot easier. This was tough, and there were so many roadblocks along the way. I didn't know that we were going to be able to do it, but we did it, and we're very happy. It's very difficult to convince patients in comparative effectiveness trials to participate because there's nothing for them, right? I mean, some have preferences for CT-guided biopsy or bronchoscopy, but those that don't have a preference, why would you have somebody flip a coin to decide how you're going to be biopsied? It's hard to convince them. It takes a long time to convince patients to participate, and it's hard on providers too, because you're running around and then you have to sit down for 20 minutes to explain the difference between CT-guided biopsy and a bronchoscopy, which we do in 5 minutes usually, but now you really have to do it because you're going to be flipping a coin. So anyway, so that's all I have. Thank you very much for your kind attention, and I'll take any questions you may have.